Good evening, everyone. I'm Dr. Naveen Manohar, Senior Resident of Dermatology at the Oxford Medical College Hospital and Research Center, Bengaluru. 18th November is celebrated as World Psychodermatology Day. As part of the celebrations, I welcome you to this webinar by the Psychodermatology Association of India on mindfulness therapies. To start off, I request the President of PDAI, Professor Om Prakash Singh, to please present the presidential address and inaugurate the event. Sir has authored over 100 peer-reviewed publications, 8 book chapters, and 2 books. He is also the editor-in-chief of the Indian Journal of Psychiatry and an editorial member of multiple journal boards. I request you to kindly present the speech, sir.
Sorry, conference is a problem. I'm audible. Hello.
Friends.
So, welcome to all. We are trying to like to start with academic program, and this is the first academic program from Psychodermatology Association India. And this
There is some disturbance, background disturbance. Finished his address.
I think we are having some technical difficulties with sir's network, ma'am. I think we can move forward
Yeah,
to the
yeah, we
next
can.
item.
Yeah, yeah.
Okay. I would like to request Dr. Sharmishta S. Deshpande, Professor and Head of the Department of Psychiatry at Srimati Kashibai Navale Medical College Hospital, Pune, to kindly deliver her talk on mindfulness therapies. Ma'am has a teaching experience of 22 years and has authored 21 national and international peer-reviewed publications. Ma'am has a special interest in psychodermatology and has contributed to the field of psychodermatology at both national and international conferences. Ma'am, please welcome and kindly deliver your talk on mindfulness therapies.
Thank you, Dr. Naveen. It's my pleasure to give this talk on the platform of Psychodermatology Association of India. I'm also thankful to Dr. Abhinita and Dr. Shrutkirti Shenoy madam, who has been my mentor, I would say, in this field of psychodermatology. Uh, and very good evening to all the audience. And let us begin with this topic. I shall like to share my screen. Is it visible?
Yes, it is. It is visible.
Okay. Yeah, thank you. So we'll begin this brief introduction to mindfulness therapies. Uh, so basically, what do you mean by mindfulness? It's paying attention to body part or paying attention to own mind in the present moment and in a non-judgmental way. So it's in short being aware of what is going on in one's mind and being neutral and accepting whatever is going on and not expecting anything but accepting. Now, mindfulness therapy, the word therapy means treatment. So, where do we use these mindfulness therapies? Mainly, these have a preventive and promotive role for health. Means it's usually used so that our normative life stresses we can handle effectively, and we are very efficient in our day-to-day work. So also if there are any minor stresses, they can be dealt with and we can become more healthier by this practice of mindfulness. So it's for everybody. It's not for only someone who has a problem, but in fact this mindfulness, it works better for those with a normal health and those who are having very mild problems. Recently, it has been used for psychosomatic, medical, and psychiatric disorders. Now, at the outset only, I would like to say that actually mindfulness is one of the techniques meant for in this spiritual field. Actually, the main goal is spiritual. But here now, today's talk, we are going to discuss how mindfulness is useful in various psychocutaneous conditions. So, initially, I will just brief about various practices, how they are done, their advantages, and so on, and then we'll see briefly how what's the evidence for the use in psychodermatology. Now, the various mindfulness practices include yoga. We all of us know what's yoga, various postures, various breathing techniques. So there also we become mindful of ourselves when we are doing yoga. Also, there are various types of meditation. So meditation obviously has a spiritual goal of getting detached from this materialistic world and knowing who am I and what am I for and so on. So also many youngsters nowadays, they practice these affirmations, that is positive self statements, and they have told me that it helps them to be neutral towards their own self, own thinking, and determine something positive. So I would say when we want to choose the mindfulness practice, we should have knowledge as well as experience of these, and whichever suits a person, that should be used in the management of distress. This mindfulness has its origin in the Buddhist philosophy. We know that life is changing every moment, and we can't get happiness from all these perishable things, like including our body, all this materialistic world. And that's why Gautam Buddha, he took the mind on the path of enlightenment for a permanent satisfaction. Now, here, when we are trying to overcome our stresses, we are mainly practicing staying in the present moment. So this mindfulness is based on the fact that most of our miseries, they are due to thinking about future, or feeling expecting some negative feelings in the future, or ruminating about the past. So either we are we get stuck to the past unpleasant things that have happened and we are not able to overcome them, or we are always worrying about what if this happened, what if this happens. So we are stuck with that what if, and then we are not just able to enjoy the present moment. So here we see so how this process of mindfulness, it helps us. So it focuses on here and now. So there is increased awareness about self. So as I said, it can be about the body as well. So we can scan the whole body from toe to head, that my toes are relaxed, my how are my knees relaxed, how are they feeling. So we are looking neutrally at our own body. So this body scan can be also done. At the same time, we can use it for our mind. So try and discover your innermost feelings, thoughts, and what is the current state of mind. Like my mind is feeling now anxious, my mind is happy, my mind is thinking about this. So we are being neutral. Okay, at the moment, yes, I am thinking about something that is unpleasant. So when you accept the moment, the next moment there is a possibility for change. So that is the main principle. And we look at it in a very neutral and non-judgmental way. We don't say that, no, why I'm getting this thought. We are not being judgmental about that, but we are looking at it in a neutral and non-judgmental way. So, what is the psychotherapy background for this mindfulness? Some people say it's related to CBT because mainly, we are trying to focus on our cognitions. But also, actually, mindfulness is more close to DBT. It's an integral part of DBT, dialectical behavior therapy, which we use normally to improve the distress tolerance, interpersonal effectiveness, and increase the emotional regulation especially in the patients with depression or those with emotionally unstable personality disorder and so on. And also mindfulness can be used as a type of meditation. Now, in our comprehensive textbook of psychiatry, this mindfulness is mentioned as mentalization based therapy. So, what is this mentalization? It's a similar term to mindfulness. It involves study of process of thinking and feeling about self, but and others also. Mentalization involves not only objectively looking at yourself but also at the others. And I think in Indian context is very very important, because half of the miseries they arise because we keep on thinking why this person is behaving in this way, why this he has not behaved properly with me, or I have been hurt by this person. So we also need to be very neutral and non-judgmental towards other people. Then only our interpersonal tolerance it's going to increase. So it's about awareness of thoughts, feelings, affects, moods, and somatic sensations of self as well as others. So that is nothing but mentalization based therapy. No, this mentalization can be multidimensional. We can do it, we can just look at the automatic thoughts about self and others. We can mentalize self or we can mentalize others. Then the mentalization can be about internal versus external components of mental status examination. In psychiatry, we have this mental status examination in which we examine the various parts of the mind. So there are certain external components like psychomotor activity, how is the facial expression, and so on. So we can, imagine or just visualize that in a neutral way, or we can have internal things like our thought, our perception, and so on. So again, the internal mentalization could be about our cognitions as well as affective, about our emotion. Now, how this looking at us neutrally, how does it help us? So it firstly reduces the distress because we are being non-judgmental. We are not getting carried away by the emotion, but rather looking at the emotion from a distance in a non-judgmental way. So, because it reduces the distress, it also reduces the physiological arousal. We know that whenever we are highly emotional, the autonomic nervous system is activated, and that leads to a lot of changes in the body as well as in the skin. So, it helps us in managing the maladaptive thought processes. So, once we are distancing ourselves, being neutral, non judgmental, our intellect helps us to identify our own maladaptive thoughts, and then we can correct it by ourselves. So it also helps in self acceptance. In many of the skin disorders also, people have negative self image, and there is reduced self acceptance. So even bodily self acceptance and psychologically, both the things can be improved. Then there is acceptance of every moment. There is better tolerance to unpleasant thoughts, sensation, and emotions, which we feel that, oh, it's so unmanageable, I can't just tolerate it. So that improves the tolerance. So for dermatology patients, mainly it reduces the psychological distress about the skin lesions, because these lesions are pretty difficult, for any person, any human being to accept that, oh, I am having such a lesion, how people must be feeling about it, or how do I feel when my skin is like this. So it reduces the skin discomfort, it improves the acceptance of the appearance, and helps in regularizing the immune function as well, and it reduces the physiological arousal, as I said, and thus it also reduces the itching. So now we'll see some studies which have demonstrated its effectiveness in reducing the itching, which is a very troublesome component of many skin conditions. However, we have to also know when mindfulness does not help. It doesn't help if there is some morbid psychiatric condition like major depressive disorder or delusional disorder, or if a person has got suicide risk. Yes, sometimes that also distress reduces by mindfulness, but we cannot just ignore it by handling it with mindfulness. Then also, if there is attention deficit or any cognitive problem, then mindfulness alone will not help. Also, if there is a very serious stressful event or a person is psychotic, has schizophrenia, then also mindfulness is not going to help. So it's not a single solution to any psychological distress, but we have to screen for psychiatric disorders and then only decide that whether this particular person will benefit from mindfulness. So we have to make a wise choice, like whether to give any psychological intervention for skin condition, like whether to try habit reversal, or what we are aiming at basically, whether he will benefit from relaxation techniques, guided imagery. There are so many options available in our basket. Now, how it is practiced, we just see in short that we sit at a quiet place with eyes closed. and there are self instruction which can be given by yourself or by some guide. Now even therapists can take these mindfulness sessions, or it can be done by oneself. So we are in a being mode or in neutral, paying attention to all the aspects of experiences, positive as well as negative. We do not attempt to change or evaluate what is happening, and this is very very important, because in our mind we are only criticizing ourselves. We are only saying that this is not good, this is bad, this should happen, that should not happen, and so on. So here in mindfulness we are not attempting to change or evaluate what is happening. We are reducing the experiential avoidance of unpleasant mood and sensation, so that improves our tolerance to the unpleasant mood as well as unpleasant sensations. Now this I include deliberately because we are talking more about the sensations arising from skin, like itch is a sensation which leads to scratch as an action. So in MBT session, mainly if there is a therapist, there is empathic validation, that is listening to the patient's narrative, appreciating the experiences, clarification and exploration of the story which is brought by the patient. Then identifying the affects, labeling the emotion often helps in dealing with that emotion. So if the patient, we encourage him to talk what is happening presently. So then he'll say, okay, at present I am feeling angry, or I am feeling disgusted, I am, feeling irritated. So he's labeling his emotions. So identification of affect itself is the first step when it comes to mindfulness. So and also we are presenting the alternative native perspectives. So mentalization, it helps in building up relationship, and also we can identify how are the attachment styles. So when the patient is mentalizing, we come to know a lot about the patient's personality and what kind of problem he is having. Now it's actually very useful thing. And so what are the advantages we'll see? Especially I would like to highlight this in the Indian context, where we have very few psychologists, and psychotherapy is a very distant thing for ordinary patient, and often they also don't have enough time. So what are the advantages of mindfulness in all this background? So basically it can be conducted for groups as well, need not be always individual. So it is cost effective, there's less time consuming, and it can soon become a self-help intervention patients can do on their own after a certain period of time. It's not very difficult to learn. Then it's applicable to community setting as well, need not be medical setting. There's no investment or costly instruments involved, and not only it helps to deal with the distress, but it builds positive health. Say if it is practiced for a long time, like 3 years, 5 years, like that, it will build a positive health and make the patient more resilient to the conditions that may arise in future. So also it leads to fear avoidance. If a person is scared of certain social situation, or if he is scared of certain doing certain things, what we call as performance anxiety, then fear avoidance can be achieved. It also allays social anxiety. There is no stigma attached to this treatment. Now, when a patient, say, referred to psychiatrists by dermatologists, often they experience that there is a lot of stigma and patients refuse to come to psychiatrists. But they are always willing for these treatments, and there's nothing, no question of religion and all involved in this. So this is a good way of handling the distress of patients. However, what are the limitations? It's not possible for actually every patient, especially if the emotional disturbance is significant. We have discussed these conditions. And another thing is regular practice is needed. You are not going to get the immediate effect. The person has to be patient enough to practice it regularly for a quite long time. So good motivation is required, and a rare possibility I would say is that it can worsen underlying psychosis or underlying severe psychiatric illness if it is missed. So we should have this in back of our mind. Now we'll see in certain skin conditions how these mindfulness-based treatments they are used. So MBT in itch scratch cycle. So it is found to be useful in chronic pruritus, urticaria, atopic dermatitis, and psoriasis. Now, these studies, they are often these studies which are undertaken, they are brief studies and not always randomized control trials. But still, whatever results they have come up with, they have reported significant benefit of these treatments in all these conditions. Now, itch is an unpleasant and often distressing symptom, and acceptance of itch sensation is likely to reduce its intensity and the habitual scratch response. So that's what they say, that whatever conditions that are especially associated with itching, mindfulness is likely to be useful. Now, itch is neutrally perceived as one of the bodily sensations during mindfulness. Like, how I'll say that my knee is little paining, I'm having itch here, then my shoulder is feeling relaxed, hand is feeling tense. So like that, if I'm observing in a neutral way, itch is also perceived neutrally as one of the bodily sensations, and that helps to reduce the intensity of itch. So research so far has reported that if we add this mindfulness to the treatment, it results in faster skin clearing, it reduces the distress, there is reduced stress and improved well-being, especially in psoriasis patients. They have studied this in psoriasis patients. Also, there is reduced itching in atopic dermatitis. It reduces also the attentional bias towards negative social experiences. This is very important because due to negative social experiences, often the patient loses on his functioning, or he is distressed, and later on he may land up in depression, and it affects his quality of life to a great extent. Now, during mindfulness, what happens is he is very looking neutrally and non-judgmentally even at other people. So that's why I said this mentalization concept. In fact, it is better because there also the person is learning to be non-judgmental towards other people, because often we don't know what is their perspective. Are they really criticizing you, or they have some their own problems? So it helps in reducing the negative social experiences. Then brief audio guided meditation has helped as an adjunct to light therapy as well. Then group therapy leads to improved quality of life in psoriasis. So there are studies in which they have done group therapy for patients with psoriasis. And along with this, the added benefit, as there is, as I said, overall improvement in the personality, making the person more positive and resilient, like improvement in self-esteem and body image is found. Then randomized control trial for this has been done only in EUPD, that is the emotionally unstable personality disorder, and it has proved to be effective. But for other conditions like depression and anxiety, it is usually used as an adjunct in addition to the usual treatment or psychopharmacology that we give. So mindfulness cannot be always, we can say that it will be effective by itself, but often it can be useful as an adjunct to the routine psychiatric treatment that is given. Now in the psychotherapy paradigm, as I said, that CBT, if you say, it's more effective for anxiety and depressive disorder. Now MBT is more like eclectic therapy, and it's involves a mixture of attachment theory, client-centered, and interpersonal therapy. So a variant of self-monitoring is nothing but this mindfulness. So we observe all the mental phenomena without giving a reaction to them. So this reduces experiential avoidance of negative feelings. So as I said, these positive feelings and negative feelings, they are an integral part of our life. We have to face them, we have to tolerate them, and we have to go ahead in life with these. So this mindfulness will help to reduce this. Everyone wants happiness, and they try to avoid sadness. So that's what leads to a lot of problems. And even this anticipation of any sad feeling or anxiety, it causes a lot of distress. So that is reduced by mindfulness, because we are trying to expose the person to all this in a very neutral way. So, in conclusion, I would say that mindfulness is effective for prolonged illnesses, and also for psychological distress. So, considering these, it's likely to be useful for many dermatological disorders. Now, it's very good that today we are also going to discuss the cases, because we have to see how clinically it can be applied or it should be used. So, theoretically, yes, it is likely to be useful for many of the dermatological disorders, uh, but excluding major psychiatric illness will be necessary before recommending it. Then promising results are there for those who can practice it regularly. So this we have to keep in mind. Then the randomized control trials, not many are done as of now, but studies have been done in many of the disorders. So definitely this is a good area for further research uh, that is needed in this area. So take-home points will be that MBT can be easily recommended as add-on with other treatments and may not suit each patient, but improvement in underlying skin condition, itch perception, and psychological stress is expected with this mindfulness therapy. Then it helps in developing overall well-being, empathy, and socially engaging with others and developing a secure attachment. So overall quality of life, overall mental health as such is definitely likely to improve if one is practicing it regularly. Now, as I was, searching the literature, I came across these books. So I feel, when we have these very intelligent patients, maybe even medical students and all who have such problems, I usually recommend them some books to read. So these two books I found are good ones: The Power of Now, and the other one, Wherever You Go, There You Are. So even by reading the books, self-help. So we are now focusing with mindfulness mainly on the self-help, how patients can help themselves, because many conditions they are chronic, and how far they will go to therapist, or how long can we help, but they have to help themselves. So these books are really good ones. Also, I always recommend this book on emotional intelligence by Daniel Goleman. It's a nice book to build up your EQ, because we see there are nowadays many intelligent people, but they lack in emotional intelligence, and that leads to a lot of psychological problem, as well as psychosomatic illnesses, as well as psychodermatological disorders. So for all these, if they work on themselves, it's really going to be helpful. So I thank the organizers for giving me an opportunity to discuss this topic. I'm also very thankful to my colleagues and friends in psychodermatology and dermatology, who have always been very supportive for me whenever I wanted to do research in this field. And I also thank my dermatology patients for making me more knowledgeable and wise, because I think clinical experience in this field is something that will really make us better and more able to help the patients. So thank you all for patient listening. The other references.
Thank you so much, ma'am. That talk was insightful for all of us, as well as for giving us interesting pointers that were clear and precise to follow. Moving on, we now move on to case discussion sessions to better understand the clinical utility and facets of psychodermatology in daily practice. I would like to introduce our presenter, Dr. Shreya Kapoor, who is a distinguished member of the fields of dermatology and clinical psychology. She is a scholarship recipient for the World Congress of Dermatology and has presented numerous papers and talks on the same topic. She is currently pursuing her diploma with the European Association of Psychodermatology. I welcome Dr. Shreya Kapoor to kindly present the first case.
Thank you for the kind introduction, Dr. Naveen. I'll just, so I think it says I can't start sharing the screen while,
Yeah, I have stopped sharing my screen. Please continue.
thank you. So I do want to begin by thanking Dr. Shenoy ma'am, who has been an inspiration in this field always. And, I've learned a lot from her, and I hope that I'll do a good job with the case presentations today. And Dr. Tarun, Dr. Abhinita for giving me this opportunity to present here. Is my screen visible to all?
Make it full screen. Yeah, it's visible.
Okay, ma'am. So I'm presenting a case of adult chronic plaque psoriasis, a 28-year-old female who presented with widespread lesions of psoriasis since 7 years. When she came to me, she was asymptomatic, but her opening statement was, I have come for treatment one last time. So a friend had brought her, and she said, I don't have much hope, but fine, I'm here. She had taken oral and topical medications previously. She was not happy with the results, which means that the disease kept recurring. So on examination, there were bilaterally symmetrical and well circumscribed plaques with silvery white thick scales on her extensor forearms, retroauricular areas, back, forehead. There was also post-inflammatory hyperpigmentation from old plaques on her legs. So overall, it was quite unsightly, and it was definitely something that as soon as she walked in, anybody would pay attention to. So for her personal history, she works as a mehndi or a henna artist. Her sleep is reduced. She said that she had trouble falling asleep. Her appetite was reduced. Bowel and bladder were currently normal. And she complained of headache and tiredness and said she did not feel like doing anything. Also statements like, I can't tolerate how they look at me. So she goes from event to event for mehndi, to do the mehndi, and she is very, very conscious of how people glance at her more than once, or their gaze lingers on her, and this was something that she expressed in this way. So of course, by this point I had understood that this is somebody where I for whom I need to take a deeper history. And so I came to taking the biopsychosocial history. As we know that to explore a psychodermatology case fully, the biological, the psychological, and the social components are extremely important. So her family was from a lower middle class. Her father had passed away 9 years ago. I wondered if the psoriasis was, a manifestation of the stress, because father passed away 9 years ago and she started getting psoriasis 7 years ago. Her mother keeps poor health, and there's no other siblings. She's the only earning member, so there's a lot of pressure on her, and there are financial constraints. Because she's a 12th pass, she has no other qualifications. She does not know what to do apart from doing mehendi. So every time she wants to explore a different job opportunity, she feels like the psoriasis interferes with that because nobody wants to take her on. Disease, so there's treatment fatigue, hopelessness, and of course a financial drain. Low self-esteem, people commenting her friends are busy in their own lives. And she also expressed that because she'd been dealing with it for 7 years, nobody was indulging in her story anymore because it was such a long and old issue now. So I assessed her with the patient health questionnaire anxiety depression scale, which is split as the PHQ-9 for depression and the generalized anxiety disorder scale for anxiety. Her total score was 25 on 48, which reported a moderate depression and anxiety. Her general parameters were okay, but the cholesterol and sugar levels were borderline. So why I wanted to show this questionnaire is because for me, where I've put this star, question number 9, it would be very difficult to ask a patient who has come to the dermatology OPD expecting a cream or a tablet, do you have thoughts that you might be better off dying? For me to bridge this gap, I thought was very challenging without this questionnaire. So I found it quite useful to have this questionnaire ready and then these questions being read or asked by me and then being answered. So I devised a treatment plan pharmacologically to start her on methotrexate, topical corticosteroids, moisturizers, and multivitamins orally. For psychotherapy, I thought mindfulness-based therapy would probably be a good idea because she did seem to be getting overwhelmed, and probably some CBT as well, because one needs to dig deeper into her own self-worth, and a lot of the family history probably is also relevant and creating traumas for her. And of course, for her lifestyle, exercise, diet, meditation would be important. So as the doctor, my concern was that how would she react to this psychoeducation that I was trying to, or I want to, do for her, that yes, you have come in for a skin condition, but I'm going to be asking some uncomfortable questions. I'm going to be talking about things to do with what you're thinking, how you're feeling, and I'm not sure what her reaction will be to this. My other doubt was, when do I start medication? If I should start medication, is it good enough to start just with counseling, mindfulness, and how long to continue the therapy sessions for. Her concerns, of course, were, will the disease go away forever? And does taking care of my mental health, when I had this initial chat with her, she said, okay, even if I do all this, is the disease going to go away then? Is it going to settle down after that? So I think that was tricky to answer. That does taking care of my mental health help with psoriasis per se? I also came across a lot of other tools which I did not use, but if in doubt, I think there are scales for every, as doctor was pointing out before, first you need to identify the effect. So if you've identified certain words that the patient has used, there is a scale almost for everything, right from isolation to loneliness. Lastly, I would just like to say that clearly from this case, it is evident that inside out is as important as outside in. This is my email address if there are any doubts or questions.
Thank
you,
you.
Dr. Kapoor. To discuss the case, I now request Dr. Shrutakirti Shenoy to preside over the discussion. Ma'am is the professor and head of the Department of Dermatology at Kanpur Institute of Medical Sciences with over 200 peer-reviewed publications and 14 textbooks. Ma'am was instrumental in initiating Psychodermatology Liaison Clinic in Manipal in 2010 and is the founder president of Psychodermatology Association of India. I also welcome the other members to the discussion panel, Dr. Shreya Kapoor, Dr. Sharmishta Deshpande, Dr. Mahendra Sharma, Professor and Head, Behavioral Medicine Unit and the former Head of Department of Clinical Psychology at NIMHANS, Bengaluru, Dr. Sudipta Roy, Director of Silence Center at Surat, and Dr. Shubh Mohan Singh, Faculty of Psychiatry at PGI MER, Chandigarh. I now hand over the stage to Dr. Shenoy ma'am.
Thank you, Dr. Naveen, for the wonderful job you are doing. You have introduced all the speakers. And it's my pleasant duty to start the panel discussion right away. And hearty welcome to all the panelists. They are each one of them experts in their fields. And I think we'll have a very fruitful discussion. And another thing is we have enough time before the second case. We have nearly we have quite a lot of time, maybe more than 50 minutes for this case discussion, and I'm sure it will be very fruitful. And has Dr. Shubh Singh joined? I'm not seeing him here. Yeah, anyway, so Dr. Shreya, it was a wonderful case, and this is the day-to-day problem what dermatologists face. Day in and out, we have at least one psoriasis patient with a similar presentation and similar problems. Now, to Dr. Shreya first, I understand you're a dermatologist and a clinical psychologist, which is a very excellent combination. You have done your MA in clinical psychology. So please tell the audience how you will manage, that is, without referring to a psychiatrist, how will you go about as a dermatologist?
So, ma'am, like I said, the first challenge for me was, how do I bridge that gap? She's come in expecting a cream or a tablet, and I need to do all of this with her. So the first thing that, I would like to do in such a case is to psychoeducate as much as possible and explain that, that there is a mind-skin connect, even though it's not visible, even though it doesn't come up on your skin. When you are stressed, there are certain manifestations which may make the disease worse. And even if it does not affect the disease per se, it will affect how you feel about it and how you manage it and how you go about your life. So I think the first thing to do is to psychoeducate and bring the patient on board that this is a requirement which is as important as taking your medicines and creams. So for her, subsequent to making this presentation, I did a first session with her where I took a slightly more detailed history to understand what her concerns were, and I felt like I need to talk to her about confidence building. So that was one thing that we started talking about. alternate options in terms of her career. So looking at the peripherals also, apart from the disease, and not making the disease center stage of her life. That was definitely something that I started venturing into. I am still to, go ahead with other sessions. I've just done one with her, but I think mindfulness, once I start off properly, will be critical to this, because being present in the now is probably going to help this patient a lot, because there was so much rumination, so many thought processes, so much anxiety about the future, that definitely mindfulness will be something helpful.
Okay, so thank you, Dr. Shreya. So what we understood from what she said is, as a dermatologist, when we see a patient, it is not treating the skin alone, because we always emphasize that holistically we have to manage. Treating the skin is only 50% of the job done. So unless we tackle the psychological issues, we will not be offering a holistic treatment. So what Dr. Shreya emphasized is, we have to do psychoeducation. We should inform the patient that there are psychological stressors which affect the condition, which perpetuate the condition. It is a disease which can be triggered and aggravated by stress. So slowly introduce this aspect to the patient and do some supportive counseling in addition to starting the dermatological treatment. So thank you, Dr. Shreya. Now coming to Dr. Sudipta. Sudipta, will you please switch on your video? Yes. Yeah, Dr. Sudipta. Now let's say a dermatologist in Surat who does not have any experience, or who has no time in psychoeducation and supportive counseling. So she is your friend and she refers this 28-year-old girl, a lady with psoriasis, to you, and do what is best for her. So how will you approach her, Dr. Sudipta?
Yes, I think, a good starting point, as Dr. Shreya said, would be to start with the psychoeducation, informing her of the mind and skin connect. And apart from that, I think I would like to probe a little more, like say, what is the role of the stressors in her life? How does she view her own body, her own self? And how does she feel when she is dealing with her clients? Because she's in a very body oriented profession, and she seems to be having conflicts regarding her own body image as well. So I think that's something I would like to probe very gently through different questions. And also I would like to probe her family atmosphere a little more, like, what's her birth order, what was the childhood like, and maybe also at the time when her father passed away, how old was she, what was she doing. So I think those things would give me some idea about possible psychological conflicts that might be linked with the condition. And then I could bring out, like, there seems to be a connection, like say if there was a connection, as Dr. Shreya tried to probe, that between the death of the father and onset of the symptoms. So we could kind of point out these connections and say, okay, and ask her how she feels about that. And would she be willing to probe and, to explore these symptoms a little further with us that way. So I think I'd proceed in that manner. And mindfulness would be a great starting point as well. And just to, if we inform her that this is a stress beating mechanism, and you could maybe take up these exercises to work on your stress, then she might, and if she's motivated and practices them, then we'll see different approaches to her symptoms in the very near future. And I'm sure Dr. Sharma would also add to a few things there. Yeah.
So thank you, Dr. Thank you, Dr. Sudipta. So Dr. Sudipta, being a clinical psychologist, I think she'll go deeper into the psychological history. She said she'll probe deeper into the history and see whether she's go further into her psychological history and see whether she's a candidate for a technique. So thank you, Dr. Sudipta. Now coming to Dr. Sharma, he's an authority in mindfulness. He has more than nearly 37 years of experience working in one of the premier institutes of our country, NIMANS. And he's an expert in mindfulness also. So, Dr. Sharma, if this patient is referred to you, what will be your approach?
Thank you, madam. It is a pleasure to see you after a long time, of course, on screen. Uh, as far as this particular patient is concerned, or any other patient, particularly patients with dermatological problems, they have a lot of body image issues plus psychosocial distress. So, as a part of uh, psychoeducation, uh, I would validate the emotions of the patient, what really one is experiencing, uh, before we move to the other aspect of the uh, psychoeducation, and working on the different aspect of mindfulness. Before that, we have to make the person understand the relevance of mindfulness uh, in her or his problem. So working on the like the acceptance ki whatever is happening is perfectly normal, like you are not responsible for your psoriasis, but whatever you are experiencing is understandable, particularly the psychosocial distress, because it is very much related with the one's identity in the society. And uh, so and also some of the aspects of the cognitive therapy, which may be added later on as the therapy progresses, where to make the person understand the different errors in thinking. So it will enrich the therapy, apart from the practice of the mindfulness, which will help the patient to uh, accept whatever is one is experiencing, plus also uh, helping the client to be non-judgmental about one's thought, one's experiences. So I will begin with like this, madam.
Thank you, Dr. Sharma. So, Sharma has given a very good introduction. He also, like Dr. Sudipta, wants to go deep into the history and actually, make a note of the exact emotions a person feels. Like Dr. Shreya mentioned, I feel, very agitated when people look at me and what are they thinking about my visions. So, a deep in the emotional history has to be taken in more depth and take a detailed psychosocial history and then plan the treatment, whether it is CBT or mindfulness. So, Dr. Sharma, how will you decide that a patient is a candidate for CBT or mindfulness? How will you decide as to what treatment is apt for her? That is non-pharmacological treatment. How will you decide?
Yeah, like the basically mindfulness uh, uh, helps the people to accept being non-judgmental, also reduces their day-to-day stress. But apart from that one, so I am more of integration. I mean, that is the where you include some very useful aspect of cognitive therapy, and plus the mindfulness therapy. So uh, uh, it is well known, I mean, that is the mindfulness does help, but there are difficulties which we have to keep in mind. It is not easy to be to accept each and everything in the very beginning, and also uh, the there are cognitive errors, so which make it difficult the practice of the mindfulness. So if client is knowing about the different errors in the thinking, what we generally call in cognitive distortion, so that will be certainly making the therapeutic process somewhat quicker than what we generally do only with one kind of therapy. So, in that way, that is the adding on the or integrating the cognitive aspects. Not that is because you see, mindful based therapies do not go into the analysis, interpretation of the thoughts, but what we do is that is we make the person educate. That is what are the different errors in the thinking. So when one is practicing and one can relate with those errors of thinking, then it will be easier for the patient over the time.
Okay, thank you, Dr. Sharma. So, Dr. Sharma has beautifully told there is no one single approach. So, he believes in taking a detailed psychosocial, emotional history, and he believes in integrating various therapies depending on the needs of the patient. So, perhaps, cognitive based CBT, and he may add mindfulness. So, he believes in understanding the patient's psyche and talking to the patient and trying to integrate the various therapies. Thank you, Dr. Sharma. Now, coming to the psychiatrist, let us hear the view of the psychiatrist. Dr. Sharmishta, please switch on your, Dr. Sharmishta. Now, the same case, this lady of psoriasis, when Dr. Shreya and when Dr. Sharma talked to them about the non-pharmacological interventions, and we also face in practice. So patients say, no, I'm not interested in yoga, meditation. Give me something to improve my mood, or I'm not interested. I'm not a person to do yoga, meditation. I can't come for sessions. So if the patient is sent to you for her mental distress, how will you tackle this case?
Okay. Thank you for the question, ma'am. I also congratulate Dr. Shreya. She has nicely presented the case, and I think this is very unique combination. That she has also studied psychology along with dermatology. Now, as far as this case is concerned, I would consider the period she is suffering this distress. For years, she has been suffering from this. And first, I would make a clinical diagnosis whether whatever she has is it dysthymic disorder, whether it's major depression, so that then I can come to the decision whether to give her psychopharmacology or just deal with it by the way of course, looking at the history. She does need mindfulness, or even CBT may help her. That is for sure, but is she in a mindset as of now to accept these treatments? That's very important. So first thing I would say that one should never hesitate to ask these questions related to mind to the patient. If we are confident, we should not feel that, oh, how will the patient feel? They will feel stigmatized. No, they don't feel. They want to get better. So if we are firstly confident that yes, I am doing the right thing by asking them all these things, I think it's really helpful. We should develop a nice rapport with the patient. And one thing, I don't know if Dr. Shreya mentioned that whether she has any suicidal ideation or not, that should be asked directly, and we have to rule out that first, because if it is there, then definitely the line of management will change completely. Yes, Dr. Shreya, want to say?
Yes, ma'am. So in that PHQ9, the last question is about, do you think you would be better off not like killing yourself or doing some harm? So she answered no for that. It was more of a, I don't feel like doing anything. I don't know what to do with my life. It was more along that lines. I did not pick up, although this question was asked, I did not pick up on any.
Right. Yeah, but I would just suggest that, rather than questionnaire, we should ask directly about suicidal ideation in person, because many a times, if that is missed, that can cause a lot of harm to the patient. So I would like to explore further from psychiatrist's point of view, and then I think in this case she will need, at least for a short period, some antidepressant. So I would prefer some low dose SSRI drug like paroxetine, because she also has a lot of social anxiety. And considering her profession, if she stops working because of this depression, anxiety, then she will further worsen in terms of mental health. So what I would prefer is initially start with the pharmacological treatment, and then also with that, when she becomes more willing, and when she's cognitively in the mindset to undergo all these therapies like mindfulness and CBT, I'll definitely recommend her these treatments. And I think she has to undertake this. Here, mindfulness will be more useful because she can learn and then she can self-help. She can do it on her own later on, because she doesn't seem to be a person who can afford going for CBT for say 12 sessions, 20 sessions to psychologists. So maybe like person like Dr. Shreya, she can explain her what is mindfulness, how it can be practiced, and that will definitely help her. So it will be a great thing to add on. But to begin with, definitely I would say that we should assess this thing and give her a short course of say 1 month or so of antidepressant, and then assess again. But of course, if it's major depression, she will need a long-term treatment with antidepressant. But that only clinical assessment will tell me exactly where do I place her in terms of her mood disorder or anxiety depression. Thank you, ma'am.
Thank you, Dr. Sharmishta. What Sharmishta highlighted is in this particular case, she has moderate depression, anxiety, and she has a job which requires interaction with others. So she feels that she needs psychotropics initially. And once she becomes more accepting, once a mental condition improves, perhaps slowly the non pharmacological intervention also could be introduced. So, thank you, Dr. Sharmishta. Now, Dr. Shubhmohan Singh is a psychiatrist from PGI. He's professor of psychiatry in PGI Chandigarh. So, Dr. Singh, this patient, when she's referred to you, how will you go about? Do you believe in starting, especially for psoriatic patients with mild to moderate depression? Do you want us to continue only dermatological treatment, or do you believe in starting non-pharmacological treatment before starting the psychotropic drugs? Dr. Singh.
Good afternoon, good evening, ma'am. I am in a car right now, so I'm being driven to Gangtok, so it's a little difficult for me.
Okay.
But what I'll say is that I think we have to understand a few things. First of all, where does mindfulness come from? Mindfulness is basically a meditative practice, and it's a very Buddhist sort of practice. And it comes from this whole idea of there are two main ways in which meditation can be approached. One is to concentrate on some point to the exclusion of everything else. So, for instance, you can concentrate on breathing, you can concentrate on a specific point or a picture or a light or whatever. That's one thing. The other way that people have found, or tradition says that the Buddha found himself, was that you could allow thoughts to come to you and you could just let them be. And the mind, he said, is like a monkey in a forest. It's very kind of fidgety. It keeps jumping from one tree to another. So the point is to let it be, to accept it, and that is where mindfulness comes from. I mean, I have never used it personally, but that's how it is. Anyway, so the point that I'm trying to make is that when we specifically with regards to this patient, I would like to say uh, that the first thing is that one has to sort of uh, assess the patient properly. I mean, I would not really give too much of importance to rating scales. They often overestimate psychopathology. The most important thing to my mind is that this patient has a chronic history, and she's somebody who's probably been through a lot of doctors, and it is very, very possible that she will just drop out. So the most important thing that I think right now is to develop some kind of a rapport between the doctor and the patient, so that she continues with that doctor for some time. And I have noticed, and it is seen many times, that rapport itself is therapeutic, in the sense that if you have a good working relationship with your doctor, that is therapeutic in itself. The second thing is with regards to medication. Often it is said that if depression is mild to moderate, one can try non-pharmacological therapies, or even, I would say, to an extent, watchful sort of expectancy, because often these things tend to sort of get better with time. If somebody is actively, severely depressed or actively suicidal or something like that, obviously one has to look at pharmacological or even other medication or other treatment modalities. With regards to non-pharmacological or psychotherapeutic measures, I think client willingness and psychological mindedness are the two most important factors over there. If somebody, if you want to have somebody who wants to sort of get into non-pharmacological treatment, it requires a lot of commitment on the part of the patient, which is not often there. Many patients have sort of misconceptions about how these things work, or whether or not they work at all, or they have very high expectations that it is a miracle treatment. But one has to understand that psychotherapeutic procedures are to a large extent process based. They take time. One has to sort of understand and see what is going on. With regards to this patient, I would say antidepressants may be not a bad choice if her depression or her anxiety symptoms are severe enough. It would probably take longer than a couple of months, but I would think that psychological mindedness is important. One has to sort of get an idea as to whether you feel a patient is sort of intelligent enough to understand what you are trying to put across. That is one thing. And the second thing is the patient is committed or has enough time to really engage in that process. And psychotherapy is a lot like one has to sort of have expectation of improvement. It's like it's a dictum in psychotherapy research that people uh, who do not expect to improve with psychotherapy do not improve with psychotherapy. It's not like a fever that comes down with paracetamol. So you need somebody who is hopeful, who is expectant of change, and is willing to indulge and is willing to commit to that process before one can start with any kind of a psychotherapeutic procedure. But I think the most important thing is rapport. There is no substitute for rapport. So I would suggest that the doctor should really try to spend time, build some kind of a working relationship, and that is where whatever else will come after that. So those would be my initial comments.
Thank you, Dr. Singh. Dr. Singh nicely summarized his approach. So just like Dr. Sharmishta, he has emphasized in particular that we have to, as a dermatologist or a psychiatrist or any mental health or a doctor for that matter, we should develop a rapport with the patient. We have to develop a rapport that is of utmost importance. What we do next comes later. So once we take the patient along with us, then depending on their mental condition and their acceptability, we can prescribe either psychotropics. So what Dr. Singh feels is start psychotropics initially, that is if they have moderate to severe depression, and depending upon their mental condition, whether they accept non-pharmacological interventions, those things can be introduced. So thank you, Dr. Singh. Now coming to Dr. Sharmishta, let's say this patient from moderate, she progresses to severe depression. She is not regular in her follow-up. And we also see in practice, because I was working in a psychodermatology liaison clinic. So we used to prescribe, our psychiatrists used to prescribe SSRIs. And what happened is once the patients go back, they discuss about their treatment with the local pharmacist. So the local pharmacist will be telling them, why are you taking this drug for your skin problem? This is given for a mental problem. So next visit, they told me, I don't have any mental problem. So I've stopped that other medicine. I'm taking only your medicine. That is the psoriasis specific treatment. So how do you approach? My first question is, patients who are not compliant with the psychotropics, how will you approach such cases? And second part of the question is, if the patients go into severe depression, because usually our patients have only mild to moderate depression, they don't have MDD, but in case they progress to severe depression, how would you approach, Dr. Sharmishta?
Thank you, madam. Actually, what I would say is whenever we give antidepressants, we should tell them that we are giving it. So there's no question of pharmacist telling them. You only tell them that, because of this mind-body connect, we need to work on your mind as well. And that's why we are prescribing this antidepressant to you. So they already know. And there's no question of pharmacist interfering in it, because even madam, she has said is, even I have seen patients telling me this, even for our psychiatry drugs, often the pharmacist says that this is taken by insane people, mad people, why are you taking it, आप तो अच्छे दिख रहे हो, आप क्यों ये दवा ले रहे हो? So even for that they keep, I don't know why they say that, but that is our usual experience. But of course, madam is so experienced, so she must have come across such patients. But what helps is explaining to the patient that what it is, why we are giving it, and also discussing the side effects in advance, that it's likely to cause this side effect, and why you have to take it, and what if you take it, and what if you don't take it. So, and the decision should be that of the patient. So nowadays, we talk of the shared decision making between doctor and patient. So we explain everything to the patient, and then let him take the decision whether he wants to take the tablet. If he says no, despite this, I want to try out psychotherapy, I very much believe in mindfulness, I want to do that, I'm sure it will help me. Then we do tell them that okay, you can go ahead, and then do get back. If it worsens, then patient they come back, and then we can. So it has to be, first of all, informed prescription, and secondly it can be shared decision making, wherein we can tell them that you also tell us whether you want to take it or not. So I think that will solve the problem. Now coming to the second question, that is, if they have this
Severe depression, if she
severe, yeah,
progresses
if
to
the severity of illness increases, then of course we do have a lot of nowadays various drugs, antidepressants. Some of them are we can use in combination also. So we'll go for another antidepressant like sedesvenlafaxine, SNRI group of antidepressant, or we will also simultaneously discuss with the dermatologist whether we can give a drug like lithium, because it's said to be excellent for suicidal ideation, but I know it's not indicated if the patient has psoriasis. So in that case, again, the liaison between the two consultants is something very important if at all the patient lands up in severe depression, because what happens is the patient may be having depression as independent illness, or it could be secondary to psoriasis. So we have to again differentiate what is it exactly. And if it is a severe depressive episode, as we call it, and or if they also have in addition psychotic features and suicidal ideation, we may also consider ECT, electroconvulsive therapy, if it is that severe, or we can give them a higher dose of antidepressant or a different group of antidepressant. But in either case, we also need to inform the dermatologist that be aware that he has severe depression. So both of us should keep in close follow-up with this patient and call him on a regular basis, say weekly or so, and assess him. And if you are giving certain drugs, obviously we discuss with the dermatologist whether this will worsen your skin condition. Because it's really a difficult decision making, and often what helps is, as I said, a shared decision between the consultants, as well as informed decision by the patient, that whether he wants to go ahead and how he wants to manage. And if it is severe depression, another thing you have to do is call the relative and inform them that your relative has got severe depression, because then they can take care of the patient with regard to suicidal ideation. If he has, or if he has such idea, or if he has some plan, if he has purchased something, some poison or something like that, then they can immediately get him to psychiatry emergency room, and we can manage that. So there are some additional precautions to be taken if it is severe depression.
Thank you, Dr. Sharmishta. So, Dr. Sharmishta has nicely enumerated how we should go about this case. So, what she feels, she has emphasized the shared decision making. So, we just don't order the drugs. We have to take the patient into confidence, explain their skin condition, explain their psychological problems, tell them about the skin-mind connect, and tell them the various therapies which are available. Some are they do not want to try drugs for mental conditions. So we lay before them various options and they are free to use any options. They can try non-pharmacological intervention. They can always tell if your psychological problem doesn't improve, then we are always there to help you recover. So what she emphasized is the shared decision-making process. Don't take everything in our own hands. We should always discuss the therapeutic options and make the patient understand and he has to choose the treatment depending on his understanding. So thank you, Dr. Sharmishra. Dr. Singh, are you free to answer questions? You said you're traveling. Can you take some other questions?
Yes, ma'am. I can answer a few questions.
Yeah. So I think there are many dermatologists who have logged into our session. So as dermatologists, many of them will be interested to know as to what are the precautions. First question is, can a dermatologist start psychotropics in the absence of a psychiatric consultations? What precaution one needs to take? And what dose should we start, and how much of updosing we can do as a dermatologist, and how long do we need to treat before referring to a mental health professional? What are your views?
I would say at a very general level, antidepressants. I'm assuming that if you're saying psychotropics, you mean antidepressants.
Yes,
antidepressants are safe. That is not an issue. The problem is to decide whether or not it is needed at all. If you are basing your prescription purely on a rating scale or something, because the point is that for most mild to moderate depression, especially mild anxiety, mild depression, antidepressants are really no better than placebo. It doesn't really help very much, or even if it does, it is a sort of a fallacious improvement, in the sense, because if a patient continues with you, you are likely to get some improvement anyway, even if you don't do anything. So the point that I'm trying to make is that giving an antidepressant or prescribing one is often not needed in that sense. So I would say that there is nothing to stop anyone from prescribing an antidepressant if you feel that there is a need for it. And it's, as I said, it's safe. There are various, SSRI or serotonin selective reuptake inhibitors like fluoxetine, escitalopram, sertraline, etc., etc. There are so many in the market. Are all very safe drugs. The usual doses are known to everyone. One has to, first of all, I would think, as a dermatologist, I would say to my colleagues that first of all, be convinced that you think that it is going to benefit the patient. You should know why you are doing it rather than anything else. If you are giving something for sedative action or something, then there are better drugs. I would personally not start an antidepressant unless I'm sure that, number one, the patient needs it. Number two, I am sure that the patient will continue on that medication for at least 1 year. Antidepressants are not to be started lightly. It is not something that you can pop like for a week or a month or something like that. Antidepressants require a substantial period of time before they start acting, number one, and then they have to be continued for a few months before you can be sure that something good is going to come out of it. Or if you have if you have achieved some kind of remission, to sort of maintain that remission also requires that you have to continue the medication. So I would think that it all depends really on your own comfort. It is something that comes with experience. I would say that if you feel that there is somebody who has significant anxiety, depression, which you think is likely to be improved with this thing, then why not? But I would say that generally for mild depression or for mild anxiety, SSRIs or antidepressants are really not worth it. If you want to give them like a benzodiazepine or a sedative, I think a sedative is probably a better choice than giving an antidepressant. So those would be my things. As a dermatologist, why not? You can give whatever you want. You are totally authorized to do that. And I would suggest that if you get a patient where you think that depression is severe or there is suicidality, then I would definitely emphasize that you should, get the patient and you should get a psychiatry consult, because that is a specialized sort of situation which requires some degree of uh, uh, application of mind. So I would think that for somebody who is not really too sort of comfortable with this kind of stuff, I would say that if when in doubt, refer. uh, if you are not in doubt, look at the simple things first. And I understand and I realize that many people nowadays prescribe antidepressants simply because they are safe, simply because they don't really harm anyone. But then you never know. And especially with elderly people, especially with people who have other medical comorbidities, there may be problems. So I would suggest that it's not really worth it. I mean, before prescribing, think twice and really convince yourself that you think what you are trying to do is going to make is going to make a difference. That is what, at a very general level, that is what I would say. I mean, the dosages, etc., are well known, and anybody can read a textbook anywhere, so there's no problem. I think. I mean, I really, to go into each medication ki itna milligram se start karo aur itna pe jao is not really the point.
Okay, Dr. Singh, well said. So I would just like to summarize what Dr. Singh told. So this is mainly for the dermatologist. So what he feels and what I feel is right is never be in a hurry. You know, if you are interested in psychodermatology, no harm. We have to take a detailed psychosocial history, ask questions pertaining to the psychological comorbidities, use questionnaires, try to be familiar with the subject. But what he has emphasized is don't be in a hurry to start, even if it is, because usually our patients have mild to moderate depression or anxiety, but don't be in a hurry to start these medicines. It's not as simple as giving a vitamin or a sedative. So what he feels is if it is given, it can't be stopped within a month or so. We have to plan a year's treatment. So many of us may not be comfortable giving it for 1 year. So what he has told again and again, he has emphasized that first we have to take care of dermatological problem. So once we take care of a dermatological problem, all the associated psychological comorbidities will definitely reduce. We should build a rapport with the patient. And if we are familiar, if the patient has really moderate to severe depression, then you may start. Nobody is preventing. But what I personally feel is because I have always worked with a psychiatrist, I have never prescribed on my own because I have not been in private practice. I have always worked in an institution. So I always refer the patient to the psychiatrist and decide whether to start. So this is a very important carry home message. We as dermatologists should treat the disease. And if the patient has itching interfering with sleep, give hydroxyzine or other sedative drugs, but don't be in a hurry to treat the depression. Even if you identify, it is always better to refer to a mental health professional. But first, we have to take care of the dermatological problem. So thank you, Dr. Singh. Dr. Shreya, you want to say something?
Yes, ma'am. I was just hoping to ask our psychiatrist one question. So one thing is Dr. Singh had mentioned, don't rely too much on the scales. They may overdiagnose. So I understand that the affect of the patient, how they come in, how they are talking to you must be taken into consideration. But sir, are there any other specific pointers that you could help elucidate, which will guide us without taking the help of the scale or relying on it too much? And the other thing I wanted to ask is, in your experience, when you have, let's say, used drugs, do you find the dermatological disease improving? Because I get asked by a lot of patients whether doing the, mindfulness or the CBT or taking the psychotropic drug, will it help with the skin disease? So these were my two questions.
Yeah, I would say with regards to your first question regarding, what are the specific pointers, I think general empathic questioning is enough. I mean, you should see, this is not, I would not say that this is not exactly rocket science. This is something that, how would you talk to a friend, for instance, if somebody was having a problem? Ki, acha, how are you feeling these days? Are you sad? Are you anxious? Are you something? So if you go by strictly a kind of a nosological checkbox approach, most people, for example, I would say that PHQ, for instance, we often administer it on patients, and we find that their responses are pretty exaggerated. I'm not saying that what they're saying is wrong or whatever, but the point is, I think there is a cultural problem with the kind of quantification that is there, the way people respond. So, for instance, I would say that in my own experience, I would think that, sadness of mood, which is kind of autonomous, I mean, to feel sad or anguished in response to a stressor, which is understandable, is not necessarily depression. What we call depression is something which is really autonomous, which has a life of its own, in the sense that it becomes a standalone thing. It doesn't go away because of certain things. If you have something which is reactive, which is problematic, it is not as if it does not merit intervention or it does not merit importance. But I would say that if you have anguish or problems or distress due to symptoms, and those symptoms, once they get better, that anguish goes away, then it does not really merit an antidepressant per se, because over there symptom control is the most important thing. So, and then what happens is that many times, for example, you are, for example, in patients with leprosy or something, where you are left with stigmata, or you are left with consequences which do not improve even with resolution of symptoms or whatever. One would think that yes, because many people do require antidepressants. I mean, it's a fine balance. You have to really individualize where you feel कि यार किसी को आपने देना है नहीं देना है, whatever. Because as I said, I mean, antidepressant institution is not something which is meant to be done lightly. It is not something that you give for a week or two, because it is really useless. It is of no consequence to give something for a week or a 10 days or 2 weeks or a month or something. It is something I always tell my patients, see, मेरे पास बहुत सारे लोग आते हैं, and I always tell them, see, I can start it only if you are committed and if you are willing to take it for 1.5 years. If that is not something you are ready for, don't even start it. कोई फायदा ही नहीं है उसका, ठीक है? So I would say that if you just want to say diagnose depression, or you want to say screen for depression in a busy OPD, I would say that you should probably ask for stuff like general sadness of mood, where you are not able to, which is sort of interfering with your day-to-day activities, that you can't work, you cannot function, or you are not finding any interest in stuff that you really that used to interest you in the past. So, for instance, if you're no longer watching TV, or if you're no longer interested in housework or your kids' homework or something like that, that is something I would say is a real pointer. Sleep disturbance is often something which is very, very sort of symptomatic of more severe depressions. Hopelessness, or this idea that I'm never going to get better and this is how things are going to be. And then there are other general sort of pessimism about the future. And if you feel that you have no energy, and if you cannot really do any sort of work that you could do earlier, I would say those are more sort of important factors. I mean, when you diagnose any kind of a psychiatric disorder, disorders are diagnosed on basis of the dysfunction that they cause. Anybody who's able to hold a job, or anybody who's able to go to work every day and is able to do whatever he or she is supposed to do, is not really, I would say, is not moderately or severely depressed. If you read ICD 10 or 11, the first thing is anybody with moderate to severe depression has significant dysfunction in day-to-day activities. So, so that is what is the most important thing. I mean, symptoms can come later. You first have to see what is the kind of dysfunction that you are getting into. So that is regarding this. And what was your second question? I just slipped my mind.
So the second question was, have you, when you're treating patients and if
Yeah,
they have
yeah.
a disorder, have you seen?
See, I would say that, I mean, interventions for mental health are not disease modifying agents, in that sense. What they do really is, it is a very, it's it depends on the directionality of what you are looking at. So, for example, if you have a mental disorder which is leading to a skin problem, so for example, if you have somebody with, say, compulsive scratching or something like that, so if you sort of look, if you tackle the psychological thing, you will find an improvement in the skin thing, right? Or if you have somebody with, say, vitiligo, some girl who wants to get married and is not getting married because of some unsightly patch somewhere or something like that, then if you have an improvement in the symptoms, it will lead to obviously better quality of life, better well-being, etc., etc. uh, but as I said, the main idea behind psychodermatology to my mind is that this whole idea is to enable patients to cope with their conditions better. I mean, that is how you should look at, because a patient may ask you, अच्छा आपको क्या लगता है जी ये करने से मेरी skin condition ठीक होगी कि नहीं? Now that depends on your own honesty, which is why I said rapport is important. Because unless you really get along with your patient and the patient accepts कि अच्छा जी जो डॉक्टर कह रहे हैं कि हाँ भाई it will enable me to live a better life, notwithstanding symptom reduction or whatever, I think that is a better sort of aim. So it is only something that should be broached or discussed when you have some degree of a rapport or some degree of a working relationship with the patient. A patient who will first ask कि अच्छा जी ये बताओ कि mindfulness से मेरा urticaria ठीक होगा कि नहीं, तो that is not something you should just say कि okay, let us discuss that at a later date or whatever. But that is not the point of the exercise, So sometimes, I mean, if you said कि हाँ भाई इससे फर्क पड़ जाएगा, I don't think it does, because there is no reason that why it should. And the point is that if you did that, that would be dishonesty on your part, and dishonesty is never a good idea. So I think that's how sort of I would look at it.
Thank you, Dr. Singh. I think Dr. Shreya has got a satisfactory answer. So Dr. Singh has given his objective views, how we have to deal with the psychodermatology case. So thank you, Dr. Singh, for your inputs. Now I would like to ask the last question to Dr. Sharma. Before we proceed to the next case, Dr. Sharma, I hope you're listening. Dr. Sharma?
Yes.
Yeah. So quite often we find that in the last 2-3 months, I've interviewed nearly 4-5 vitiligo and psoriasis patients, and I expected them to be having, significant psychological morbidity. But when I asked them, they appeared cheerful. They didn't have any negative feelings. I asked them to fill the scales. I referred to the psychiatrist, but they didn't have any psychological comorbidities. So what is the explanation? Do you think they are hiding their problem, or they have good coping skills? So how will you assess such patients who deny psychological issues?
Yeah, it is very much possible that patients might be not having diagnosable psychiatric disorder, but issues like anxiety, social anxiety, or distress, concerns which are there, they may be present. It depends on the patient's personality also, how they take. I mean, that is, there are the people who accept their problem, okay, if it is there, what can be done? And if they might have gone through this process, and if the uh, illness is chronic, then also because of the person's temperament or personality, it is possible that one may not have a diagnosable psychiatric condition in terms of anxiety or uh, 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 depression. But one may have general concern related with body image, or with uh, social distress going among the people there, getting prepared to hide the lesions, or these kind of things are not uncommon. But uh, as you have observed, it is possible. You see, not that always one will have, that is. because it also depends on the duration of the illness. Because if you are seeing the people in the initial stage, then what would happen that they have hope. I mean, that is, they are going from one good dermatologist to the another good dermatologist. So hope is there, and so that also keep them functional and may not develop diagnosable psychiatric condition.
Thank you, Dr. Sharma. So I think we come to the end of the first case. We had a very fruitful discussion. And thank you to all the panelists. Now we move on to the second case. Dr. Shreya is going to present a pediatric patient. Over to Dr. Shreya. Dr. Shreya?
Yes, ma'am. I'm just beginning screen share.
Yeah.
Sorry about that. Is my screen visible?
Yeah, it's visible.
So the second case is that of a 12-year-old girl with atopic dermatitis. So she came to the OPD presented with redness, severe itching, flaking of skin on her face, neck, chest, cubital foci, buttocks, hands, feet. Honestly, there were fewer areas spared to count than involved. It was a rapidly progressing condition since 1 year, and she was in a fair bit of distress. So on examination, the lesions were excoriated. They were oozing a thin, sticky discharge on scratching. Some lesions, as you can see here in this image, were lichenified, and the itching aggravated at night and on sweating. Also on examination, her nails were shiny. So her personal history, she had childhood asthma. Currently, she was not asthmatic, but she had asthma around the age of 5 to 6 years. Her sleep was disturbed. She said, when I asked about sleep, she said, I get bad dreams, a lot of thoughts, so I have trouble falling asleep. Her appetite was reduced. She came with her mother, so she was able to tell me about reduced appetite, bowel bladder. She was constipated, and she had been treated with many creams in the past. As we know, with atopic dermatitis, it settled for some time and then it would flare up again. So I have taken an attempt at drawing a genogram here. So the patient is the circle in red, age 12. That's her. As you can see, she has two younger siblings. Her parents, now the larger circle is the family unit that lives together. So it's the grandmother, parents, and three siblings. The bidirectional arrow here indicates conflict between the grandmother and the mother. Why we need to also look at this holistically is to understand what is the support structure offered to this patient by her family. So this is the unit that she lives with. Her maternal grandparents live in a different city, so not of immediate support. She has an uncle and an aunt on either side of the family, but not close relationships. And she also has this uncle here, if you see on the left-hand side, extreme left, who is an alcoholic. So it's a half-shaded rectangle pointed here. So we look at her biopsychosocial history. As I pointed out in the earlier presentation also, this history is, it's a cumulative understanding of biological, social, and psychological aspects and how they integrate to affect a person, especially a child in this case. So her father works in the local municipality. Her grandmother is on dialysis. Her grandfather was on dialysis. I'm sorry, he passed away. And the grandmother and mother do not get along. There are tension and family quarrels, as I indicated in the genogram. She also has two younger siblings. Financially, the father is the only earning member, so definitely it's not a good socioeconomic status. She has not been going to school since 6 months because the school principal told the mother not to send her to school. So this is, of course, a municipal school, and the principal communicated that other children and their parents were afraid that this was a disease that could be passed on. Socially, of course, her friends are not playing with her. Classmates were bullying her when she was attending school for fear of contracting the disease. I came across this mechanism, in a review by Verhoeven et al., and I thought it was interesting. Of course, we'll expand on this in the discussion, but here are internal factors like personality, and I think Dr. Sudipta also mentioned attachment styles. So it's very interesting how a person's innate behavior and personality play a huge part in how they cope with any disease or situation that they're presented with. Then, of course, we know there are external stressors. The combination of these two, along with your cognitive factors like how much you're worrying, how helpless you are feeling, your behavioral factors like the scratching, the action of scratching, the fact that you want to avoid talking about this or confronting this issue, taking it head on, social factors, as we discussed in this child's case, her friends and peers have played a huge role in the social factors by bullying her and demeaning her. All of this leads to further worsened itching, which then impacts sleep, which then impacts the day-to-day activities, and we are in a very vicious loop. So as I mentioned, I found it easy to ask these questions and validate my questioning, because using a scale sometimes does make at least the parent understand that we are getting somewhere with this. It's not a random line of questioning. Again, they come in expecting dermatological treatment. So to shift to a psychological line of questioning, a scale helps me. I used the RCADs here. So for her treatment plan, I started her on cyclosporin, 3 milligrams per kg per day, topical corticosteroids, moisturizers, and multivitamins. So for psychotherapy, I definitely thought it was important to explore habit reversal, progressive muscle relaxation at bedtime, routine building, and mindfulness. I have done one counseling session with this patient, and I was astonished by how much a 12-year-old feels and conveys. She was so preoccupied by the thought that she was ugly, and she kept saying multiple times, even when I tried to ask about other things, she would come back to the fact that she was feeling that she is ugly. She feels tired all the time. She was restless and uneasy. Actually, I should have mentioned earlier, the reason I went into a biopsychosocial history for her was because of how much she was fidgeting in the 10 minutes that I saw her in OPD during her first consult. So she was carrying a water bottle and she opened it and shut it and drank water from it at least 5 times in 10 minutes. She was just, constantly sort of touching her hands and rubbing her face and uneasy, uncomfortable. And she did say this as well when I probed further. She even spoke about how she cries often. She gets very angry. She doesn't know what to do when she feels like this. So she shouts at her mother. She gets headaches. She has many thoughts, and she peels her skin when she is agitated. She confessed that she cannot concentrate on studying because her mind is preoccupied elsewhere. And she said that usually I keep my mother's phone with me. It keeps playing in the background, and then I try to study on the side. So in that first session, I just took a detailed history and suggested morning and bedtime breathing techniques. I suggested, I showed her the progressive muscle relaxation that she could implement at bedtime. I also talked her through a few grounding techniques to use in acute situations, because I realized that if she is around people her age group and something triggers her, she definitely goes in a downward spiral then. And my plan going forward is to introduce habit reversal techniques. As Dr. Singh said that, in this case, I do feel that stopping the plucking of skin will actually help the dermatological aspect of things. So this is a picture of the diary she is maintaining. I've asked her to be consistent with exercise. She's, started listening to music. You can see at the bottom, she's maintaining a little chart. And I think it's a good start. Maybe I'm hoping to take this forward with her. These are my references. I didn't have pictures of this child, so I used images from this article, but the severity of involvement was very much similar. And in closing, I would just like to say that, children are particularly impressionable. They're like clay. And I would urge all dermatologists to just maybe spend 60 seconds to understand if there is a deeper and an underlying issue with children of atopic dermatitis or other chronic skin diseases, because it affects every stage of their life. And it kind of they turn into adults who are either traumatized by their skin condition or who were victorious in coping and managing it. So I think it's extremely important to pay attention to this. Thank you so much.
Thank you, Dr. Shreya. It was an enlightening case, and especially I was impressed with the way you worked it up. It is a good a plan of action. You showed us the genogram, and you also told about the biopsychosocial history, and it was a good workup. But I have a question for you, Dr. Shreya. How easy or how difficult it is to get such a detailed history from a 12-year-old child? Did you do it alone with her, or was her parent along with her, her mother?
So, ma'am, the first consult, of course, her mother was with her, and I broached this subject somewhere in the middle of my consult, saying that I am seeing a lot of restlessness in the child. Is she like this at home as well? What do you feel? And then the mother quickly jumped on and said, yes, she's like this. She doesn't eat, she doesn't sleep, she sometimes is shouting. So definitely there was some cooperation because the mother had things to complain about. And once I had that with the mother, I said that, I think it would really help this child if we could talk about some of the things that are bothering her, because I understand that having an appearance like this, she must be so conscious with her friends. And then, the mother sort of segued into how she stopped meeting friends, how she stopped socializing. And from there on, she was willing to give this a chance. And she was a little skeptical because she said, are there going to be medications? What is this counseling? So I said, it's like this conversation that we are having, except that I want to ask her a few things. If you will permit, I would like some time with her alone and some time with the both of you. I'm happy if her father also comes in. So I kind of left it open in that sense to her comfort. And then in the next session, both the parents came. I had about 15-20 minutes with all three of them. And then I said, would you be comfortable if I asked her some questions alone? And I think by then they were comfortable to do that. And then I started talking to her.
Thank you, Dr. Shreya. So the carry-home message is for pediatric patients. Again, the key word is building a rapport. So building a rapport not only with a child, you have to be friendly, build a rapport with the parents too. So building a rapport building is of utmost importance. And then you start your sessions in a leisurely way. Everything need not be asked in the first session. rapport building is of utmost importance. Now, moving on with this case, Dr. Sudipta, how do you tackle these pediatric cases who are referred to you? Because pediatric patients are not, little adults. They are totally different. It's very, very difficult to manage. So, what is your approach? Is it different from managing or investigating an adult?
Yes, it is indeed quite different to work with a child than an adult. Because the techniques of interviewing or the kind of relationship we build with the child will be very different. There's a tendency in adults when we are meeting with children to kind of talk like a child, but it's not a very good idea to do that. It's much better to be an adult and to meet them as an equal. Pretending that they are more equal to you generally gives you a better look into it. But what we do is generally I tend to engage them a little bit in conversation and play regarding their likes, dislikes, or hobbies, and knowing a few things about what kids are doing these days helps you to kind of inquire, like what are the TV shows they watch, what is it that they like to see on YouTube. If we have a little bit of idea about that, we can start that as a conversation. And in the therapy, we work quite indirectly because we're not really telling them, oh, you're stressed out, that's why this is happening to you. But we kind of resolve it through play, art techniques, drama techniques, and those kind of things. So I think it is a very different ballgame working with them. But the beauty of it is that they generally show quicker results than adults. And like we said, even for the adults, that having a good rapport with them right in the onset really creates a world of difference. If the child is happy, like if the child feels accepted when they come to your chamber, you'll see that the change is already occurring. Because so many of these people with skin disorders face so much of rejection in actual society that just the validation of their presence becomes a big issue. So if we can give that validation, we are happy to see them every time they come to us, we can have a little conversation, those things itself begin to bring about a change in the child case. Yeah.
So do you think it is just talking to the patient in simple language, or do you think that they'll benefit? I mean, should we give some scales? There are specific pediatric scales. So do you think that is needed, or do you use it in practice?
Yes. I actually rely quite a bit on assessments. So there are projective assessments which we can use to help identify subconscious elements that might be bothering the child, or might also help us to identify the ways of communication. Like, say, in the case that Dr. Shreya discussed, there seems to be anger, which is, aggression is one of the main issues, and self directed aggression is also there in her case. There might be an underlying sadness and depression. So, using scales and mainly projective techniques, drawing techniques, or writing stories, these techniques help us to identify their issues more clearly. Yeah.
Her main issue is, she has widespread skin lesions, and they look, they are hyperpigmented. It does not look good, the external appearance, and she has severe itching. And another important thing is her teacher has told her not to come to school. So she's not going to school from 6 months. So how do you actually practically tackle these things? Because the skin treatment takes a long time. It is nothing miraculous. With whatever we do, it takes a long, long time. So how do you tackle these simple issues of not being able to go to school, not being accepted by other children? How do you tackle?
So that's a really tough situation because, see, on one hand, I would not like the child to miss out on education at all. Okay. But at the same time, in this kind of a case, I'm extremely worried of her getting rejection again from peers and other people, and facing bullying. So I don't want her to attend school. But generally, what I would do is, like, create a kind of an alternate atmosphere. If there is already one present, that's great. But otherwise, I would like she kind of goes to a place where, which is more safe, warm, and comforting for her for the purpose of learning. It could be an individual tutor, it can be a family member. Very often I engage my interns only at the center to provide that for some time, till the child is in a, as the symptoms start reducing, then we convince the school that, now with these changes, she's in a better space, and you can allow her to come from now on, or at least allow them. We insist that they allow them to sit for tests and exams, and make sure that we prepare them. So once we manage these things, after a while, maybe 6 months down the line, things get easier for the child. Yeah.
So thank you, Dr. Sudipta. So what Dr. Sudipta says is managing a child is really difficult. It is not as easy as we think. It takes a lot of time, patience, and we have to speak to the parents about the condition, and also, if needed, speak to the teachers also.
That's right.
I'm sorry, upper respiratory tract infection. So I was down with severe cough. I'm sorry about it.
It's very kind of you to manage the program despite those discomforts.
So, can you hear me?
Yes, ma'am.
Yeah. So I'm very sorry about my cough. Now coming to Dr. Sharma. Dr. Sharma.
Yes, madam.
Yeah. So we do understand the difficulties in tackling a child, when it comes to a child patient. So in your experience, I'm sure you must have been referred patients for behavior habit reversal therapy for chronic itchy conditions. So what has been your experience in tackling children with itchy conditions? I would like to know your personal experience.
Yeah, one thing is very common in such patient is that they are very desperate because of the age where they want others' attention, uh, because of the physical maturity, interest in opposite sex also develops, and that is the part of life. So, though it is difficult to initiate with them, but once rapport is built up, as Dr. Shreya also has pointed out, and also Sudipta was also highlighting the same point. And what is important for us is that patient who is coming to us is really distressed, and once we built up some hope, I mean that is then naturally like when person is having hope, and also her or his emotions are understood, then naturally involvement in the therapy or whatever technique we suggest in a busy OPD also are found to be very useful.
So, Dr. Sharma, do you think they are amenable for mindfulness-based therapies, children?
Yeah, as far as mindfulness is concerned, we have done with the adults and children. We have done one RCT with school children. Of course, they were not they were normal children, but my experience with the children is that they are very receptive. And if we give them opportunity by simply asking them, apart from your skin problem, what is troubling you the most, you will get so many um, um, things from them which they will narrate, and they will uh, express their emotions, their concerns. Uh, so uh, uh, we it is not much difficult. I mean, there is generally they are open, and they our experience says that is they are amenable for mindful based approaches.
So, Dr. Sharma, if you have to tell a dermatologist about habit reversal, could you just summarize the steps as a dermatologist, how we can advise behavior modification or habit reversal, especially for itchy conditions?
Yeah, mainly you see, like there are one is like the habit reversal will go simultaneous. Like first thing is that is the educating about the condition. Itching is normal in this condition, and notice that is key. It is something which is not there, and person is. So it is little different from what we see the other habits. I mean, that is here is the condition. So most important thing is the awareness. I mean, that is the where it is occurring more, whenever happens more. This record is needed. We also train the people in JPMR, progressive muscles relaxation, or any other relaxation training, which bring down the arousal level, and bringing the arousal level also help in the experiencing lesser experiencing of the itching. And so by being aware, uh, and rather than mean that is uh, like immediately attending the itching, one can suggest to go slowly and do it with awareness. I mean, that is not to create more problem, or scratching can be done in such a way that is it is just to soothe oneself. That is. So these are the some of the procedures which can be suggest to the such patients. Hello.
Thank you, sir. I think Dr. Shenoy probably is having a connection issue.
Okay. So,
But thank you for that, because I was also wondering, was GPMR the right thing to introduce, talking about that, for a child? But she took on quite easily. I think she was quite amused when I made her lie down and, okay, do this. And then she got up and said, "Oh, I'm feeling nice now." It was a very nice moment at that time. So it's good to hear that you also would have recommended PMR. Yes, ma'am is back. Yes, ma'am.
Yeah, I've joined from my mobile. There was some problem with my laptop.
yeah.
So, Dr. Sharma emphasized that, yeah. Yeah, so Dr. Sharma emphasized that it is not difficult. Children make good clients. Only thing is we should have the knack of, taking the children into our confidence. According to him, it is not very difficult. We can manage children. And he says that they are very expressive, and they will certainly tell about the problems they face. And regarding habit reversal also, he says that they should be aware of their habits. Sometimes the itching becomes automatic. So they should be aware of the habit. And also he feels that in all these patients with itching, we have to treat them, we have to train them in simple relaxation techniques which can be minimized. So thank you, Dr. Sharma. So
Yes,
coming
welcome.
to Dr. Sharmishta. Thank you, Dr. Sharma. Dr. Sharmishta, so how will you approach a pediatric patient who is referred to you? Now, this patient, if she is referred by a dermatologist to you with, to screen for Dr. Sharmishta. Dr. Sharmishta, yes.
Yes, yes, madam. Thank you for the question. For children, also first clinical assessment will be done. Uh, Sometimes children also do have major psychiatric disorders. We need to rule out that. In this case, I think this Dr. Shriya has very nicely assessed the biopsychosocial model for this case, which is really very helpful in the case assessment. And she has also taken a nice approach of handling the psychosocial things first. The additional thing I would do is refer her to the psychiatric social worker, who may kind of coordinate with the school teacher and see if she can be again sent back, or whether she can sit for a 1 hour or 2 hours, something like that. So maybe the additional role of psychiatric social worker may be there in this case. And otherwise, definitely psychosocial approach is the first one to be undertaken for children. Only if they have very severe psychiatric problems, yes, we can also try pharmacotherapy for the children in case the anxiety is very severe and disabling. um, and that's it. That- we can't hear you, madam.
Yeah, so thank you, Dr. Sharmishta. Dr. Sharmishta has emphasized that, as she has some family issues, quarrels at home, and the teacher not permitting her to attend school because of unsightly appearance, we have to take the help of a psychiatric social worker who will interact with the parents, who will meet the teacher, explain about the condition, and see that the child gets back to school. So thank you very much, Sharmishta. And Dr. Sharmishta, as a dermatologist, do you think a dermatologist, uh, is it safe for a dermatologist to start any medications in case of severe anxiety or depression? Do you think a dermatologist should always refer children? What is your opinion?
Yeah, I do feel that they should refer such a case to psychiatrist, because children, starting medication in children is again more challenging, and we need to be more used to prescribing these drugs, and should be more aware of the side effects as well. So I would say it's better to refer to a psychiatrist. And when I say refer, I am not saying that we should refer off. The child would need simultaneous care by both the professionals. And in some of the cases, even we can say that, okay, now we have selected the molecule, the dose, now that can be continued by the dermatologist as well. So it depends on the case, basically. But I think there is no harm in taking opinion of psychiatrists rather than starting the treatment on their own.
And there are some controversial issues, or is it resolved that SSRIs in children can induce suicidal ideations? Is it true or myth?
Yeah,
SSRIs, antidepressants in children.
no, no, that's the paradox. That can happen in adults as well. We have to monitor them carefully. That is why I said it's better to refer to psychiatrists, because in children also we do see suicidal ideation, suicide attempt and we have to select a molecule. SSRI is not the only antidepressant available with us. There are so many other drugs, so many newer drugs which can be used. So it's always better to refer to the psychiatrist.
Okay, so very important carry home message. Unlike adults, the children may be very susceptible to the side effects, and it is always wise and safe for dermatologists to refer pediatric patients to a mental health professional. So as dermatologists, I think the carry home message is treat the dermatosis to the best possible extent and advise simple behavior modification techniques for itchy dermatitis, that is for atopic eczema, simple ways, non-pharmacological interventions. Then if it is really needed, if the mother complains of some real psychological issues, then always refer. So that is the carry home message. So we have another 10 minutes. Dr. Singh, are you still available to answer questions? Dr. Singh? Is Dr. Singh available?
Ma'am, his name is not showing up here, so maybe not.
His name is not showing up. No? So maybe he's left. So I would like to ask Dr. Sharmishta, do you have any personal experience now as you're interested in psychodermatology? You might have had a reference from dermatology in, for regarding the itchy dermatosis or atopic dermatitis in children. So do you have any personal experience handling these children with dermatological issues and psychiatric problems?
Yes, madam, we do get some children who have these problems, and actually they do respond well. And as actually Sudipta ma'am was saying, they do respond very nicely to the intervention, even the psychological intervention, and they are very much open to discussion. We feel that how we can talk about emotions with children, but actually they are often very authentic and very genuine in expression of their problems. So we do have managed such children, and also we have tried psychopharmacology with these children at the age of say above 5 to 6 years of age. We do prescribe medicine as well, and in very low doses we get very good effect in these children. And also some cases of lichen planus, prurigo nodularis, and we have managed, even with minimal doses of medication, and we did have very good results. Um, so I would like to say that yes, for children, and use of scales would be recommended, use of assessment scales, because sometimes verbalizing ability, the way you can verbalize your problem, it's not equal in all the children or even in the adults for that matter. So in that case, these scales really help out in making a diagnosis. So if the child is not verbose enough, is not able to express his problem, then maybe to the parents also, there are a lot of checklists which like child behavior checklists, they can be filled up by the parents as well. So we have some checklists for the parents, and from their history also we can make a diagnosis. So like that, we have had actually quite a few children as well, and they do improve with the management. The only thing is having that open mind of referring the child and parent to psychiatrists and explaining them the problem. Because this problem of stigma and reluctance of going to psychiatrists is even much more in case of children than adults. So that's the problem, in fact, we have come across. And in such cases, actually, I have sometimes gone to the dermatology OPD myself, and we have together interviewed the child and the parents, and that had really helped in accepting the treatment.
Yeah, thank you very much for your inputs. And another thing is, especially parents, especially it's the mother who has to bear the brunt of having a atopic child. So if there is one atopic child in the family, is enough to disrupt the sleep and lives of not only the child but also the parents. in particularly the mother. So there is a strong possibility that the mother will have psychiatric issues, irritability, and that the condition usually doesn't improve. I mean, there's no cure for atopic dermatitis. So do you spend time with parents also, or as
Uh,
dermatologists, should we interview and spend more time with the mother in trying to understand their problems?
Yes, madam. It's very important point actually you have raised, because I have read also and I have seen also that mothers of atopic children often have anxiety disorders. It's much more than non-atopic children. So we have to manage, and sometimes treating the mother will cure the child automatically. We need not give any medicine to child. But if you only manage the anxiety of the mother, the child gets better. I did have one or two cases like that. The mothers were extremely anxious, and when we managed anxiety of the mother, uh, the way those mothers, if especially if the child is totally with the mother all the day, then the anxiety of mother definitely has an negative impact on the child. So we need to manage that, and that itself can give a big relief for the child. So even in this case, like nicely, Dr. Shri has taken the genogram and all, she should also assess the mother, as she was interrupting in between. She has given quite a few pointers that maybe mother was also over anxious in this case also. So assessing and managing, yes, that's very important thing in a topic.
So thank you, Dr. Sharmishta. So very clear carry home message, especially in the children with chronic itchy dermatosis. Not only the child, the parents have to be interviewed, especially the mother. In Indian families, it is the mother who gives, maximum attention and is available at home. So in the Indian families, it is the mother who has to be assessed, and for any mental health issues. So all these things we have to consider when we treat atopic children, or for that matter, any chronic dermatosis in a child. I think we have come to the end of our session. So I would like to thank all the panelists. They did a wonderful job, right from Dr. Sudipta, Dr. Mahendra Sharma, Dr. Shubmohan Singh, and Dr. Sharmishta, and of course, the most important person who presented the case, Dr. Shreya. So she did a wonderful presentation. It was a very practical approach, which I think all dermatologists should follow. So all in all, I think it was a useful session for the participants. And thank you all for your inputs. Thank you. So over to Dr.
Thank you,
Naveen.
madam.
Thank you, ma'am.
Thank you, ma'am. Well, and on well. To draw the curtains on tonight's events, I professor and head at the Oxford Medical Hospital and Research Center. Please present the vote of thanks.
Good evening, everyone. Thank you all for being a part of this insightful and enriching webinar on mindfulness therapies organized by Psychodermatology Association of India. It is indeed a pleasure to express my heartfelt gratitude. First and foremost, I would like to extend my sincere thanks to each one of you for participating and making the event a truly collaborative and engaging experience. I would like to express my gratitude to our president, who was very encouraging, and a special thanks to Dr. Sharmishta Deshpande for her enlightening talk on mindfulness therapies. Her insights and expertise have undoubtedly deepened our understanding of the topic and opened new avenues for exploration. Heartfelt gratitude and appreciation to Dr. Shreya Kapoor for presenting two compelling cases for discussion. The depth of her analysis and the clarity with which her cases were presented have been truly commendable. I would also like to extend my gratitude to Dr. Shrutakirti Shenoy ma'am for moderating case-based panel discussion with the distinguished panel of experts, which includes Dr. Mahendra Sharma, Dr. Sudipta Roy, Dr. Shreya Kapoor, Dr. Sharmishta Deshpande, Dr. Shubmohan Singh, and I thank all the panelists for their expertise and thoughtful contributions by adding a layer of richness to the discussion, leaving us with valuable takeaways. A special mention to all the attendees for their active participation. Your participation has contributed significantly to the overall success of this event. A big thank you to the PDAI Scientific Committee headed by Dr. Tarun Narang for designing this thought-invoking event, and Dr. Naveen, my colleague, who worked to ensure the smooth execution of the webinar. Finally, I would like to extend my gratitude to Print, Media and IPCA Company for our academic partner for this event. As we conclude this event, let's carry forward the knowledge gained and the connections made today into our professional and personal lives. We look forward to have more enriching experience in the future. Once again, thank you all for making this webinar on mindfulness therapies a resounding success. Have a wonderful evening. Thank you.
Yeah, thank you.